Hey everyone, welcome. In this explainer, we're going to break down some key pediatric kidney and genitourinary disorders. But we're not just going to list facts. Our goal is to map out the why behind them so you can actually visualize the step-by-step progression of these diseases, which is so crucial for your exams.
All right, so here's our game plan. We're going to kick things off with a couple of big inflammatory conditions, then we'll jump to a really dangerous systemic syndrome, touch on some important congenital defects, and then we'll wrap it all up with the absolute must-know takeaways. All right, first up, glomerulonephritis. Now, the key word you need to lock in your brain here is inflammation. But here's the twist. It's not a direct kidney infection. Nope. It's actually the body's own immune system that's launching the attack and causing all the trouble. So, what does that actually mean? Well, think of it like this. It's a classic case of friendly fire. Your body does a great job fighting off an infection, say strep throat, but the weapons it used, these little things called immune complexes, they don't just vanish. They float around, get to the kidneys, and end up causing a ton of collateral damage to the glomeruli, which are the kidney's super important filtering units. So let's really walk through this step by step, because this is where it all clicks. First, you have the trigger, right? A strep infection that was probably a week, maybe even a few weeks ago. Then, the internal cascade kicks off. The body makes all these antigen-antibody complexes to fight the strep, but they get stuck in the glomeruli. This causes a big inflammatory mess, damaging the filters, and finally, you see the external signs. The filters are all clogged and damaged, so fluid backs up, blood pressure skyrockets, and red blood cells start leaking into the urine. See that progression? Okay, so that's what's happening on the inside. What do you actually see on the outside? Well, all that fluid retention, that's what gives you the periorbital edema, that classic puffy face, especially in the morning. The damaged filters are letting red blood cells sneak through, which is why the urine gets that distinctive, smoky cola color. And that positive ASO titer, that's your smoking gun. It's the lab test that proves a recent strep infection was the culprit. All right, let's switch gears a bit. If glomerulonephritis was all about inflammation and red blood cells getting out, nephrotic syndrome is a completely different beast. This one is all about protein. We're talking a massive, uncontrolled loss of protein. You've got to know these 4 classic signs. They are the absolute hallmark of nephrotic syndrome. It's like a domino effect. First, you get massive proteinuria, just huge amounts of protein spilling into the urine. That, of course, leads to low protein in the blood, or hypoalbuminemia. The liver senses this and goes into panic mode, pumping out more stuff, including lipids, which causes hyperlipidemia. And finally, without protein in the blood to act like a sponge, fluid leaks out into the tissues, causing all-over edema. And this diagram, it just lays it all out perfectly. Look, it all kicks off with that damage to the glomeruli at the top. This makes the filters super leaky, but specifically to protein. So tons of protein, especially albumin, just pours out into the urine. Since there's not enough albumin left in the blood vessels to hold onto water, that fluid escapes into the body tissues, causing that massive edema. And you can see the liver over there trying to help, but actually making things worse by cranking out all those lipids. It's a perfect cascade of events. So you can see how this plays out when you're looking at a patient, right? The urine is going to be dark and frothy because of all that protein. The edema isn't just around the eyes, it's everywhere, generalized, leading to huge weight gain and even fluid in the abdomen. And here's a huge differentiator from glomerulonephritis. Notice the blood pressure. It's typically normal or even a little low because so much fluid has shifted out of the blood vessels. All right, let's be honest. These two get mixed up all the time on exams. They both involve the glomerulus, so it's easy to get confused. So let's put them side by side and nail down the differences for good. Seriously, this table is pure gold. Screenshot this, write it down, whatever you need to do. Let's zero in on those bolded points because they're the key. For glomerulonephritis, think high blood pressure and that cola-colored urine from all the blood. For nephrotic syndrome, think normal or low blood pressure but massive protein loss and high lipids. If you can master this chart, you'll be set. Now here's something that's super important, a real-world clinical pearl that applies to both of these conditions. You know, with all the fancy tests we have, what's the single best way to track fluid balance? It's simple. Daily weights, consistently at the same time every day. It's the most effective and useful tool you have to see if you're winning the battle against fluid retention. Okay, moving on. We're going to pivot from those primary kidney inflammation issues to a systemic disease that just absolutely wrecks the kidneys as part of its rampage. We're talking about hemolytic uremic syndrome, or HUS. The main thing to get about Hughes is that it hits hard and it hits fast, usually in little kids. It's most often kicked off by a toxin, like the one from E. coli, which causes widespread damage to the tiny blood vessels all over the body. But the kidneys, with all their delicate blood vessels, just get hit the hardest. Okay, exam alert. If you see this classic triad on a test question, anemia, low platelets, and kidney failure, your brain should immediately scream HUS. Let's break it down. The toxins literally shred red blood cells as they pass through damaged vessels, causing anemia. The body uses up all its platelets trying to patch the damage, leading to thrombocytopenia. And all those damaged vessels in the kidneys get clogged up, leading to acute kidney failure. This triad is HUS. All right, let's switch gears one more time. We've talked about diseases that mess with kidney function. Now let's look at a couple of structural problems, defects a baby is born with. We're just going to quickly hit two common ones you have to know, epispadias and hypospadias. And this image makes it super simple to see what's going on. It's all about the location, right? Where's that urethral opening? In epispadias, it's on the dorsal or top surface. In hypospadias, it's on the ventral or bottom surface. And if you're trying to keep them straight, I've got a super simple memory trick for you. Think epi, like on top, so the opening is on the top surface. For hypospadias, think hypo means low or below, so the opening is low, on the bottom surface. Easy, right? Okay, but here's the big clinical takeaway, and this is a classic exam question. If a baby is born with either of these, you do not perform a circumcision. Why? Well, because that foreskin is like gold to the surgeon. They often need to use that tissue to help reconstruct the urethra during the surgical repair. So no circumcision until after the repair is done. Okay, we have covered a ton of ground. So let's take a deep breath and boil it all down to the absolute must-know, high-yield facts for your exam. Think of these as your mental flashcards. When you hear glomerulonephritis, you should immediately think strep, high blood pressure, cola-colored urine. You hear nephrotic syndrome, massive protein leak, puffy all over, high lipids. In HUS, that's the toxic triad, anemia, low platelets, and kidney failure. Lock those in. And to wrap it up, let's hit those must-know clinical actions. No matter what's causing the fluid issue, what's your number one priority for monitoring? Daily weights. It's the best indicator. And for those congenital defects, hypospadies or epispadies, remember, delay that circumcision. The foreskin is needed for the repair. These are the kinds of application questions you'll definitely see. So let me leave you with this question. Now that you can really visualize what's happening inside the body, that whole cascade of events, how does that change the way you look at the patient on the outside? When you see that first bit of puffiness around a child's eyes, you're not just seeing a symptom anymore, are you? You're seeing the start of that whole inflammatory cascade we talked about. That connection, right there, is what takes you from just knowing facts to really understanding.